Examination of the abdomen. Inspection. The patient should lie flat on his back with legs extended. The whole abdomen from the nipples above down to the saphenous opening, thus the inguinal and the femur rings are exposed, must be exposed. Examination should be carried out in a good light, preferably in the daylight. First, inspect all the hernial orifices. It is a good practice to start from the bottom. This should have been the last part of inspection, but if this examination be left for the last, it may be missed and actual cause of acute abdomen may thus remain in the dark. Contour of the abdomen. Distension of the abdomen in acute intestinal obstruction occurs gradually and may not be evident till sometimes has elapsed. Distension is central in case of small bowel obstruction, whereas in peripheral, in large bowel obstruction, in volvulus, the sigmoid colon and the cecum distension almost immediately appears. In second stage of peptic perforation, slight distension may be evident. On the contrary, in biliary colic, acute cholecystitis, acute appendicitis, and renal colic, the contour of the abdomen remains normal. Respiratory movement. Sluggish or no respiratory movement of the abdominal wall indicates widespread irritation of the peritoneum, as occurs in diffuse peritonitis, perforation of the peptic ulcer, or hemorrhage into the peritoneal cavity. Ruptured ectopic gestation. Similarly, localized limitation of the respiratory movements occurs in localized irritation of the peritoneum from inflammation of the underlying organs, that is acute cholecystitis, appendicitis, etc. Peristaltic movements. The characteristic ladder pattern peristalsis may be found in small bowel obstruction. Watch for a while patiently to detect visible peristalsis. Look for pulsating swelling. In case of leaking abdominal aneurysm, the patient may come with acute pain in the abdomen. Skin. Discoloration of the flank, grey under sign, and bluish hue around the umbilicus colon sign are occasionally seen in late cases of acute hemorrhagic pancreatitis with extensive destruction of the pancreas. Sometimes there may be redness and even blisters on the skin at the site of the pain. This is an indication of hot application to the site of the pain to get relief. Palpation. During palpation, methods should be adopted same as those mentioned in chapter 34, examination of the chronic abdominal condition. 2 point needs special emphasis on this chapter. They are the volar surface of the fingers are employed for palpation. The forearm should be kept horizontal along the level of the abdomen so that the fingers are placed flat on the abdominal wall. They must not be held vertical to poke. Figures 33.3 and 33.4. During the palpation of the volar surface of the fingers should be employed and moved gently as in pile running. The forearm should be kept horizontal along the level of the abdomen. The second figure, that is figure 33.4, the fingers are held vertical to poke the abdominal wall. This is a wrong method of palpation. The abdominal wall, rough palpation will lead to voluntary contraction of the abdominal muscles of the patient. This will definitely stand in the way of obtaining right information from palpation. The clinician must keep his hands warm before palpation of the abdomen. This will gain confidence of the patient. Hyperesthesia. Sometimes cutaneous hypersensitivity can be obtained due to the presence of the inflamed abdominal organ underneath. This can be elicited by gently picking up a fold of skin and lifting it off the abdomen, or by simply stretching the abdominal wall with fingers. Presence of hyperesthesia in Schwan's triangle, that is formed by lines joining the umbilicus, anterior superior iliac spine and the pubic symphysis, is regarded as a good guide in diagnosis of general gangrenous appendicitis. If this hyperesthesia disappears during the process of illness, it indicates bursting of the gangrenous appendix. An area of hyperesthesia between the 9th and the 11th ribs posteriorly on the right side is known as the Boas sign. It suggestive of acute cholecystitis. Tenderness is constant over an inflamed organ. Ask the patient to point out the site of pain. Pointing test. If this proves to be the site of maximum tenderness, it is certainly the site of disease viscous. In acute cholecystitis, tenderness is present just below the tip of the 9 costal cartilage on the lateral margin of the right rectus. In acute appendicitis, tenderness is present on the McBurney's point. This point is situated at the junction of the lateral 1/3 and middle 2/3 of the right spino-umbilical line, joining the right anterior superior iliac spine to the umbilicus. It is a good practice to ask the patient to show the tender area. If he is not definite about it, he may be asked to cough when a sharp twinge of pain may be felt over the inflamed area. Note carefully the degree and the extent of the tenderness. This indicates severity of the disease. In doubtful cases, one can percuss the abdomen. Presence of tenderness over the inflamed organ can be easily revealed by this technique. The bed shaking test buffet can be applied whether early peritonitis is still on doubt. The foot end of the bed is moved slightly, and this will evoke pain at the position of the inflamed organ. Spread of tenderness, if present, should be noted. In acute appendicitis, there is tenderness also on the left iliac fossa. It indicates spreading peritonitis and demands immediate surgical intervention. Similarly, in case of peptic ulcer perforation, tenderness may be elicited in the right iliac fossa as gastric contents gravitate along the right parabolic gutter. Very often, a case of peptic perforation has been diagnosed as acute appendicitis due to the presence of the right iliac fossa tenderness. Figure 33.5 and 33.6 showing how to elicit rebound tenderness in a rebound tenderness. In second figure, that is figure 33.6, the hand of the patient clinician has been suddenly lifted and the patient scams with pain. Appendicular tenderness can be elicited in left lateral position when the viscera shift to the left, exposing the appendix to the direct palpation. The abdominal wall also becomes relaxed in this position. Differentiation from thoracic disease. Diaphragmatic pleurisy or basal pneumonia often refers pain to the abdomen, can be made by the fact that in these conditions the skin may become hyperesthetic, but no definite tenderness can be elicited from deep palpation. Further, if these cases complain of pain in the right iliac fossa and mimic appendicitis, pressure on the left iliac fossa will fail to elicit tenderness on the right iliac fossa, which is known as Rovsing sign, which is typically present in appendicitis. Rebound tenderness, Blumberg sign or release sign. This is mainly a sign of peritonitis due to presence of an inflamed organ underneath. The suspected area is palpated with each expression. The hand on the abdomen is gradually pressed down as the circumstances may allow. The hand is now withdrawn suddenly and completely. As a result of this abrupt removal, the abdominal musculature springs back into its original place. The patient will immediately cry out or at least wince in pain. This is due to the fact that the parietal peritoneum, which has already been inflamed due to the presence of underlying inflamed organ, also spring back along the abdominal muscles. This sudden movement of the inflamed peritoneum is very much painful in presence of abdominal guarding due to generalized peritonitis. This test may not be necessary. Presence of this sign in acute intestinal obstruction suggests strangulation of the gut. A few tests of eliciting tenderness are discussed below. Rovsing sign. If the left iliac fossa is pressed, pain is appreciated on the right iliac fossa in the case of acute appendicitis. This is due to the fact that the coils of ileum shift slightly to the right and press on the inflamed appendix. This is a very important test to differentiate acute appendicitis from similar other abdominal conditions. Cope's test. A retrocecal appendix lies on the posterior psoas major muscle. Eliciting Rovsing sign in the left iliac fossa is pressed and the pain is appreciated in the right iliac fossa in case of acute appendicitis. Method of eliciting psoas test. The right thigh is being hyperextended, which will initiate pain in case of retrocecal appendicitis. Note the position of the Stern's triangle indicating by dots. Inflammation of the appendix will cause inflammation of the psoas major muscle, which is concerned with fixation of the hip joint, flexion of the hip joint. When the right hip joint of the patient is hyperextended, this muscle is stressed. This will initiate pain in cases of retrocecal appendicitis. The patient is turned to the left and the right thigh is hyperextended. Method of eliciting Cope obturator test. The lower limb is being internally rotated, which will stretch the obturator internus and will initiate pain in the pelvic appendicitis. Obturator test. A pelvic appendix may lie on the obturator internus muscle. When this appendix becomes inflamed, internal rotation of the hip will stretch the obturator internus and patient will wince in a pain. Ball wing test. The hand is placed over the flank of the patient. The patient is now asked to raise the right lower abdomen of the bed, keeping the knee extended. The patient will immediately complain of pain in case of retrocecal appendicitis. Retrocecal appendix remains close contact with the psoas major muscle, which becomes contracted during the flexion of the hip joint. In the passing, it must be mentioned that in case of retrocecal and pelvic appendicitis, tenderness and rigidity may not be that prominent on McBurney's point. Here lies the importance of the above mentioned test, which becomes positive on retrocecal and pelvic appendicitis accordingly. Muscular rigidity, muscle guard. Muscle guarding is an excellent indication of irritation of parietal peritonitis. This may be due to the inflammation, presence of blood or contents of hollow organ within the peritoneal cavity. This is a part of the protective mechanism, which is also seen in case of irritation of the parietal pleura with restricted movement of the chest, irritation of the synovial membrane with restricted movement of the joint, and irritation of the meninges in case of meningitis with rigidity of the neck. It is utmost importance to differentiate voluntary from involuntary muscle rigidity. While involuntary muscle rigidity or muscle guarding indicates underlying parietal peritonitis and one which the clinician is very much looking for. The voluntary muscular rigidity is simply rigidity of the abdominal musculature brought about by the patient himself due to fear of being hurt or reminiscent due to exposure of the abdomen. Method of palpating the abdomen for muscle guard. The hand in contact with the abdomen feels for the muscle rigidity, whereas the hand over it applies the pressure. During palpation, the hand must be placed flat on the abdomen using flexure surfaces of the fingers as the palpating media and must not try to poke the fingers deep into the abdomen. Gentle movement of the straight fingers will be able to find out the presence or absence of involuntary muscle guarding. This should be carried out all throughout the abdomen so as to detect localized muscle guard if present. Another method of eliciting involuntary muscle guard is to use both hands during the palpation, one above the other. The hand in contact with the abdominal wall remains passive and wholly utilized to feel the condition of the abdominal musculature, while the hand above is used to exert a slight and steady pressure to assist the hand below for better palpation. Patient confidence must be gained by being gentle in your behavior. You must ask the patient to open his mouth and breathe deeply in and out. Unlike the involuntary muscle guarding, the voluntary muscle guarding will disappear during expiration and helps the clinician to palpate in a better way. The muscle guard usually corresponds to the area of tenderness. Presence of a muscle guard over the upper half of the right rectus muscle in a patient who is seized with a sudden pain over the same region is strongly suggestive of perforation of the peptic ulcer and demands immediate surgical intervention. The surgeon should not wait for board-like rigidity of the whole abdomen, which is a late feature of this condition. In case of appendicitis, the site of muscle guard varies according to the position of the appendix. In case of paracecal appendix, the rigidity will be present over the right iliac fossa, whereas in case of retrocecal appendicitis, it will be present all over the loin, and in pelvic type there may not be any rigidity of any of the anterior abdominal wall. Muscle guard will be conspicuous by its absence in case of all colics due to absence of irritation of the parietal perineum. Similarly, acute intestinal obstruction without strangulation will not show any rigidity of the abdomen. Differentiating rigidity due to thoracic disease from due to perforated peptic ulcer is made by asking the patient to take deep breaths in and out with open mouth. During expiration, the rigidity will be diminished in case of thoracic disease, whereas in case of peptic perforation, it is always present. Distension. In case of acute intestinal obstruction, there will be central distension of the abdomen. The coils of intestine will be felt to harden and soften alternately. Generalized distension of the abdomen is a late feature of generalized peritonitis, and the patient must not be allowed to reach that stage under any circumstance. Appendicular lump may be felt in the right iliac fossa. If the case is brought late to the surgeon, carefully palpate the lump, noting its position, size, shape, consistency, and mobility. Appendicular abscess, cold abscess, and intestinal hernia also produces lumps and should be differentiated. In intussusception, the sausage-shaped lump may be felt in epigastrium or lumbar region. It is usually associated with empty right iliac fossa, synedance. Palpation of the internal hernias is very important. Quite a large number of cases of acute intestinal obstruction are due to strangulated hernia and can be very well managed by timely operation. Percussion. Light percussion may be employed to elicit local tenderness. Shifting dullness. Presence of free fluid in the peritoneal cavity can be determined by eliciting shifting dullness. When the patient lies on his back, the fluid gravitates down to the flank and the intestine floats on the center of the abdomen, which will therefore be resonant and the flanks full. Percussion should be commenced from the center of the abdomen and is carried out to the flank. At the point where the dullness starts, the finger is kept in its position and the patient is asked to turn to the opposite side. The particular area is again percussed after waiting for a few minutes to allow the fluid to gravitate down. Now the note will be resonant to make the shifting dullness test positive. There are many acute abdominal conditions and surgical importance in which free fluid can be accumulated in the peritoneal cavity. These are perforation of the peptic ulcer, typhoid ulcer, acute pancreatitis, rupture, ectopic gestation, etc. Eliciting shifting dullness. The abdomen is percussed from midline towards the flank. When the percussion becomes dull in the flank, the patient is turned to the opposite side. The figure shows that the flank is again percussed and note becomes resonant. Fallacy. Abnormal retention of the enema may lead to distension of the intestine. In these cases, shifting dullness test may be positive due to shifting of the fluid inside the descending or ascending colon as the patient is rolled over. So the test becomes positive without presence of free fluid inside the peritoneal cavity. Fluid trail. This test has been discussed in chapter 34 of examination of the chronic abdominal conditions. It also indicates presence of free fluid in the abdominal in a large quantity. Obliteration of the liver dullness. Right mid-axillary line is percussed from above downwards. The percussion note will be resonant in The upper part of the mid-axillary line. At the upper border of the liver, the resonant node is replaced by dull node. If the liver dullness is replaced by the resonant node, it indicates presence of free gas under the diaphragm, as occurs in perforation of the gastrointestinal tract. It must be remembered that the absence of this sign does not exclude perforation, since this sign will only be absent when there is sufficient leakage of air. Demonstrating the presence of resonance over the area of the liver dullness by percussing along the right mid-axillary line about 3 inches above the costal margin. Resonance here indicates gas under the diaphragm. Fallacy. Considerable distension of the gut and emphysema of the lung may obliterate the area of the normal liver dullness. Auscultation. This is a very important part of the examination in acute abdominal conditions and should never be omitted. The patient should be familiar with normal peristaltic sounds, noting their character and frequency by studying them in healthy abdomen. The silent abdomen is a pathognomic feature of diffuse peritonitis. Even localized absence of peristaltic sounds will be evident around the acute inflammation of the organ concerned. To the contrary, a noisy abdomen is a feature of acute intestinal obstruction. Normal intestinal sound is heard as a click, gurgles, but in intestinal obstruction, distinct metallic tinkles, or borborygmi can be heard. In case of peritonitis or paralytic ileus, when the intestinal sounds are absent, particular respiratory and cardiac sounds may become audible. Measurement. The role of distension in acute intestinal obstruction or paralytic ileus or post-operative peritonitis can be assessed through repeated measurements. Rectal examination. No examination of an acute abdominal case is complete without the digital examination of the rectum. The right wall may be tender in pelvic type of appendicitis, which may not show any tenderness or rigidity of the anterior abdominal wall. Tenderness is often elicited in rectovesical pouch in perforated peptic ulcer. The bulging of the anterior wall of the rectum which tenderness is significant of a pelvic abscess. In endosusception, after the rectal examination has been finished, one will find the gloved finger to be smeared with mucus and blood, red currant jelly, but there will be no fecal odor. In majority of cases of acute abdomen, there is ballooning of the rectum whose significance is yet to be found out. Auscultation of the abdomen is of great value in differentiating peritonitis from intestinal obstruction. In peritonitis, the abdomen is more or less silent, whereas in intestinal obstruction, increased peristaltic sound can be heard. Vaginal examination. Purulent discharge and tenderness in both fornices are suggestive of acute salpingitis. In cases of ruptured ectopic gestation, the cervix feels softer, and in any movement of the cervix will initiate pain. General examination. When the abdominal findings are not sufficient to account for symptoms of the patient is complaining of, and one should think of extra abdominal causes and proceed to the examination in following way. Examine the chest and the chest wall. Pain is often referred to the abdomen from thorax in such conditions as diaphragmatic pleurisy, basal pneumonia, angina pectoris, myocardial infarction, etc. Pain may reflect from the upper and middle lobes of the right lung to the right hypochondrium and may wrongly lead to the diagnosis of acute cholecystitis. Similarly, referred pain from the right lobe to the right iliac fossa may lead to the false diagnosis of acute appendicitis. Abdominal distension, if present, aids to confusion. Typical findings of pneumonia may be lacking, but presence of fever, hurried respiration with lowered pulse aspiration in ratio, walking of the Ehlers-Danlos, and absence of vesicular bleeding all lead to a probable diagnosis of lobar pneumonia. The chest must be thoroughly examined in every case of acute abdomen in diaphragmatic pleurisy and basal pneumonia. Pain is often referred to abdomen. The spermatic cord and the scrotum should always be examined for evidence of filariasis in case of acute abdomen. Cases are on record when the patient complains of acute pain in the abdomen when the pathology lies in the testis. Example, pain complaint in the right iliac fossa in case of torsion of the testis. Abdominal pain sometimes in a child may be due to an acute epididymitis. In case of children, confusion is much more due to the lack of good history. Thoracic compression test is by compressing the lower part of the chest from the side to side will bring about pain in presence of thoracic disease, but not with typical acute abdomen. When the pain radiates from the back along one or more spinal nerves of the lower thoracic segment to the midline anteriorly, one should think of the herpes zoster as the probable condition. This often leads to confusion with acute cholecystitis, but Skin hyperesthesia along the whole course of the affected nerve. Absence of rebound tenderness may clinch the diagnosis. Examine the scrotum and the spermatic cord for evidence of filariasis. This may lead to acute abdominal pain from retroperitoneal lymphangitis, swelling, redness, and tenderness of the groin due to filiary funicularis supposed by periodic fever should suggest this condition. Examination of the spine for Pott's disease. Compression of the spinal cord or more often, the intercostal nerves by granular tissue of Pott's disease may cause referred pain in the abdomen to mimic an acute abdomen. Examine the nervous system to exclude Taves dorsalis. It may lead to the gastric crisis consisting of pain in the abdomen and vomiting. A history of lightning pain in the legs, Argyll Robertson pupil, that is, pupil not reacting to the light but retaining the accommodation reflex, and absence of ankle or knee jerks will settle the diagnosis. Spine should be examined to exclude Pott's disease when the patient complains of abdominal pain. There are a number of medical conditions which may mimic an acute abdomen. These are malaria, porphyria, diabetic crisis, sickle cell anemia, hemophilia, etc.